DHHS makes a determination within their available budget and within their available cash to the mental health agency who will be awaiting their payment from June 30th to July 1st. Because mental health in state law, the department refers to a division of state-operated facilities and a division of community health services. But in the Appropriations Act and in the state law, there is one division, and they operate out of the same checking account. So who's affected by that, I think, would be a function of who is in greatest need, who has the greatest ability to withstand a time lag in getting their reimbursement for services. What underlies the shortfall? Typically, it's attributed to the state-operated facilities. And there's a history of it that goes back to 2008, when this first occurred, and it has continued through the current year. The good news is that various measures have been put in place by the department that are starting to whittle away at what that shortfall is at year end. So where they came into this year with a fairly significant shortfall, we were able to carry forward money to bring it down to $22 million, and it has been further reduced by another $5 million in the current year. The obvious question on this slide is, if an agency has unfunded liabilities, why would they have a reversion of state appropriations? The money that reverted, and I'd like to pull out my note if I may. The money that reverted, and we discussed this in the state budget office because typically there is no reversion for mental health. We carry forward anything remaining so that it can always be used to liquidate those liabilities, to continue to reduce that and make progress. But in the case of this year, there was an appropriation of $4.6 million for supplemental short-term assistance for group homes. This was primarily to, you all know better than most, this was to help mitigate the impact of people who had lost their Medicaid coverage for PCS services because of a change in the eligibility standards. The language that was included in special provision said in section 12A.2a, and this is subsection D, subsection C, that the department shall terminate all monthly payments pursuant to this section on June 30th, 2014. And in section D said, the department shall not, under any circumstance, use any portion of the $4.6 million appropriated in this act for this purpose, for any other purpose. So in that regard, we believed that that was required not to be carried forward, not to be used for other liabilities, but to go back to the general fund so that it could be reappropriated at the discretion of the General Assembly. Some carry forwards. I touched on this in the beginning of the presentation. The state and the accounting system does not have any way to keep cash that is appropriated for the general fund and make it non-reverting. So general statute advises us that when there are funds that are unexpended and unencumbered, that they will revert to the fund from which the appropriation was made. When we evaluate what is unencumbered, then we take into consideration in the state budget office, all requests for carry forward come to the state budget office. And there's three primary areas where we evaluate a potential carry forward. And that is for cash deposits that don't belong to the general fund. And the Medicaid example is a good one. The pharmaceutical companies gave rebates to the Medicaid agency late in June. And those the federal share of that, we know that when we buy drugs, it's state and federally funded. When we get a rebate, it's state federal funds that come back in. The mechanism the department uses for settling up due to, due from with the federal government is through their drawdown of federal funds. And there was not a drawdown that was going to occur before the end of June. So that was cash that we would say is in the checking account but not belonging to the state. So that was taken out. Funds that are required by statute to be non-reverting, I can walk through as many of those as you'd like to hear about, but there's various places where the General Assembly in statute over the years has said an unexpended appropriation in one place shall be carried forward and used for a particular purpose. And finally, we look at documented encumbrances. The next slide gives you a total of what we carried forward by the particular categories. So unearned revenue of $36.7 million, you can see that the lion's share of that, $35.8 million, was carried out of the Medicaid budget as federal funds not belonging to them. And that included the drug rebates, and that included where NC tracks, they call it unapplied cash. I guess that's a term of art to refer to, I recouped a payment, and I know that when I made the payment it was state and federal, so a portion of my recoupment is federal, and I need to take that out of the state's cash. The next category of documented encumbrances, $14.2 million, again, the largest piece of that was money that was appropriated on a non-recurring basis for the new Broughton Hospital. And you will recall that in the actions of the short session of the General Assembly, let me back up, in the original 2-year appropriation bill, there was this $11 million appropriation for the facility coming online to equip it, to get the technology, the medical equipment, and other things that were needed. There was then a second year appropriation for the same thing of a little over between $16 and $17 million. That second year appropriation was taken back by the General Assembly as a savings in the money report item for the short session. This money was carried forward in lieu of having that second year appropriation so that there would be money in this year's budget as the Broughton Hospital facility comes online and requires that equipment and technology investment to make it operational. And then finally, the last category that we had are documented encumbrances, required by the general statute. So of the $3.7 million referenced here, the largest piece of that is the statutory requirement that the U.S. Department of Justice settlement funds shall not revert but be carried forward and to satisfy the terms and conditions of that settlement. So in total, that's the 3 categories, that's the grand total of cash that was carried forward. After we go through the carry forward process, the very final thing that we report on is what came back to the taxpayers for the appropriations balance to the general fund. So this schedule shows you by division each division's contribution. And what I've shown in this slide is their share, I hope I labeled it adequately, but it was the state dollars that the state general fund appropriations for each of those 11 distinct appropriations categories that reverted at June 30th, and the percent that reversion represents of their total enacted appropriation. Medicaid is about 63% of what was reverted within the Department of Health and Human Services. And to put it in a statewide perspective, Medicaid, DHHS, the state's reversions were right around $400 million, so DHHS was roughly 25% of the total, and the total here represents 2% of the department's general fund budget. To the chairs, that concludes my prepared remarks.
Thank you, Ms. Kirkpatrick. Before we move into questions for Ms. Kirkpatrick, I did want to welcome the new State Budget Director to the Oversight Committee on Health and Human Services. I'm sure we'll be spending a lot of time together in the coming months, but Mr. Roberts, appreciate you being here on your second day on the job, I think, and if you have any comments you'd like to make this time, please feel free to do so. Hit the push on.
Thank you very much. I'm glad to be here, and I look forward to working with you and the members of the committee.
Representative Dowell.
Thank you, Mr. Chairman. Pam, it's good to see you again, as always. So, just to give some perspective, I mean, we ended the year, the most recent budget year, in the black in Medicaid, and if you could give us maybe a little bit of perspective, when was the last time we were in this great shape in terms of our Medicaid budget and the department's budget overall?
Thank you, Representative Donner. I knew I should have brought my history of reversions and problems and gaps in Medicaid, but I'll tell you what I have with me, so I think I can answer the question. Because in the department slides, they're using the numbers that we have recorded for Medicaid shortfalls over a period of years, but I do have this handy 14-year history of what's happened with reversions across the department. And I was looking at this prior to this meeting, and I see that starting in the year 2006, we started transferring money into the Medicaid budget, $13 million that year. In 2007-08, there was a $9.2 million transfer. We had the big blip on the radar screen in 2008-09 when the department reverted $603 million, which happened to coincide with a ginormous overdraw of federal Medicaid funds. And from that period forward, every year until this year, there has been some form of Medicaid shortfall, whether it was managed through transfers of other DHHS resources or by appropriation of the General Assembly.
Follow up.
Follow up.
In your professional opinion, in your experience with Medicaid, which is several years, shall we say?
Yes, sir.
Wouldn't you say that we are certainly in the best shape that we have been, at least since 2006, with respect to not only the bottom line on Medicaid, but if you would maybe expand a little bit about some of the things that have been dealt with, particularly over the last 4 or 5 years, where there were literally hundreds of millions of dollars in certain cases of off-budget items that needed to be resolved that, for the most part have been resolved. We still have, one relatively small item that we've been working on for several years on that $14 million, I guess, that the department is still working on with the, that came from the hospitals and that sort of thing, state's hospitals. But if you would comment on some of those items, another one that comes to mind is a number of years ago, there was a payment to the federal government for the federal drug rebates that was kicked from the end of one fiscal year to the beginning of another fiscal year, sort of created a 13th payment. That was finally resolved a couple of years ago. But could you just comment on the how we were in really tough shape in a variety of ways, and how we are really in far, far better shape today in terms of all the underlying budget issues we've been working on for the last 4 or 5 years?
Yes. So there was a lot of real estate covered in the question, but I think if I could try to address it from the fact that over the years, yes, we've had a number of problems within the Medicaid budget, whether it was lack of visibility into payments and obligations that were off budget, that were not considered because the way the budget process worked. We talked about a rebase, and we talked about policy changes, and we never talked about one-time payback. So a good example of that was that ginormous, there's probably a better budget term, somewhere around $350 million federal overdraw that occurred back in 08 or 09. And And so then we went through this process of the department trying to cobble together resources to make those payments coming back to the federal government. And one of the budget process improvements that was made was a better presentation both through to the executive branch and to this body of what those obligations were, and a better communication about what was a rebase item and what was an obligation or a one-time commitment. So certainly much improvement in identifying those things that somehow over time got to be called off-budget items. Also, I think a lot of improvement has been made in looking at not just forecasting one part of the budget for Medicaid. There's always this focus on Fund 1310 because it's the provider payment fund. And we always like to talk about that it's $10 billion. Well, for goodness sakes, there's another $4 billion we need to talk about. And I think that this body, between the executive, the department working to try to do a better job in identifying requirements in the Medicaid budget that are influenced by the population served and the value of claims, whether that's doing a better job in estimating contract